study. Okay. Now, first one, what is this peptic ulcer? Peptic ulcer is a condition where the erosion of GIT mucosa will happen. Why this erosion of GIT mucosa will happen? Because of excess HCl production or because of exposure to pepsin enzyme. Okay, usually our GIT mucosa will be exposed to the HCl and pepsin. But in certain conditions, what is going to happen is because of excess HCl and pepsin or because of other condition, there will be erosion of GI mucosa will happen. Okay, this erosion or removal of GIT mucosal cells because of these acids and enzymes is called as ulceration. Okay, and where it occurs, it usually occurs on the abdomen and on the stomach and urine. Okay, why it happens? It happens due to imbalance between aggressive factors and defensive factors. In stomach, we have two type or two category of substances are there which will protect the GIT mucosa and which will damage the GIT and which will protect the GIT mucosa. We call it as a aggressive, defensive factors which will damage the GIT mucosa. We'll call it as a aggressive factors. And the aggressive factors are HCl, pepsin, and H5. Whereas defensive factors are gastric mucus, bicarbonate, prostaglandin, and nitric oxide. These are the defensive factors which will protect the GIT mucosa. Whereas another group of substances, that is aggressive factors, which will damage the GIT. Okay. Now, if you see this image, in this image, this part is called as erosion of GIT mucosa is called as ulcer. Why it is happening? It is happening due to excess HCl secretion and due to excess pepsin secretion and due to decreased defensive factors. Okay. Now, physiology. In our stomach, we have two types of or two category of substances are there, that is protective factors or protective substances and aggressive substances. Protective substances include mucus, bicarbonate, prostaglandin, and mucosal. Aggressive factors include acid, pepsin, NSAIDs, and Helicobacter pylori. In physiological system, what is going to happen? These will be maintained as a balance. That is, protective substances and aggressive substances are present in equilibrium. Now, in pathological condition or in ulcers, what is going to happen is the protective factors weight will be decreased, or the substances, that is mucus, bicarbonate, prostaglandin, and mucosal blood flow will be decreased and associated with increased acid, increased pepsin, with drugs like NSAIDs, and with microorganism like Helicobacter pylori. These are the aggressive factors which causes peptic ulcers. Okay. Now, physiology of gastric acid secretion. How the gastric acids will secreted. Gastric acid and enzymes are secreted. This gastric acid secretion is regulated by the neurotransmitters, paracrine, or which are the local hormones, and endocrine. These are the chemicals which will regulate the gastric acid secretion. The neuronal or neurotransmitter which will regulate the gastric acid secretion are acetylcholine, and paracrine hormone which will regulate the gastric acid secretion are histamine, and endocrine hormone which will regulate the gastric acid secretion is gastrin. These are the substances which will regulate the gastric acid or which helps in physiological release of acid secretion in the stomach. Okay. Now, how this image is important, how the acid is secreted. Now, this cell is called as parietal cell. Parietal cell is a cell which is present in the stomach, And what is the importance of this cell? This cell helps in acid secretion. Now, on the parietal cell, we have a gastrin receptor. Now, gastrin will come and bind to the gastrin receptor, thereby increases the intracellular calcium levels. Whenever the intracellular calcium levels are increased, then it activates an enzyme called as protein kinase. Whenever protein kinase is activated, then this protein kinase will activate the proton pump. And what this proton pump will do? This proton pump help in transport of H plus ions from the parietal cells to lumen of stomach. Now, in the lumen of stomach, this H plus ion will combine with the chloride ion to form HCl. This is how HCl is produced from the parietal cells. Okay, and the triggering substance is gastrin. Gastrin will come and bind to the gastrin receptor, thereby it increases the intracellular calcium. Whenever there is increase in intracellular calcium, it will activate an enzyme called as protein kinase. Whenever protein kinase is activated, it causes activation of H plus K plus pump, which is also called as proton pump. Now, next one is histamine. Histamine will come and bind to the H2 receptors which are present on the parietal cells. What is going to happen when histamine come and bind to H2 receptor? It will activate an enzyme called as adenyl cyclase. Now, what is going to happen if adenyl cyclase is activated? This adenyl cyclase will convert the ATP into cyclic Whenever the cyclic AMP is produced, it in turn activates protein kinase enzyme. When protein kinase enzyme is activated, it causes activation of proton pump, thereby helps in transportation of H plus ion from the parietal cells to the lumen of stomach. This is how histamine will helps in secretion of HCl. Next substance is prostaglandin. Now, prostaglandin, that is PGE2, come and bind to the PGE receptor on the parietal cells, and what it will do? It will inhibit the enzyme adenyl cyclase. Okay, PGE receptor will inhibit the adenyl cyclase enzyme. Now, what is going to happen if adenyl cyclase enzyme is inhibited? There is no conversion of ATP to cyclic AMP. If there is no conversion of ATP to cyclic AMP, then there is no activation of proton pump will be seen. So thereby it decreases the acid secretion. That's why PG or prostaglandin E is present in which category? In defensive category. Okay. Now next one, acetylcholine will come and bind to the M1 receptor present on the parietal cells, thereby increases the intracellular calcium, which in turn activates the protein kinase, and this protein kinase activates the proton pump, and thereby HCl acid or H plus ions will be transported to the lumen of stomach, where it combined with the chloride ion and will form the HCl. Okay. Now, the drugs which helpful in peptic ulcer are, first one is antacids. Well, what these antacids will do means these antacids will react with the gastric acid and increases the pH of stomach. Next one is H2 blockers, drugs like ranitidine, which will block the H2 receptor, thereby inhibit the acid secretion. The next group of drugs are proton pump inhibitor. The drugs include omeprazole, which will inhibit the proton pump, which is also called as H plus K plus ATPase, thereby inhibit the transfer of H plus ion from the parietal cells to the lumen of stomach. Okay. Next group of drug is misoprostol. This one is a prostaglandin analog. This misoprostol will come and bind to the PGE receptor and thereby inhibits the activation of adenyl cyclase. The next drug is proglumide, which is not therapeutically used, which is an antagonist for gastrin. The next one is factors regulate the acid secretion. Now in this image you can clearly see how H plus ion will be transported from parietal cells to the lumen, and how Cl chloride ion which will be transported from the plasma into the lumen of stomach, and in the lumen of stomach H plus will combine with the chloride ion and Cl minus ion, and it will form HCl. Okay, the main important substance here that regulate the acid secretion is H plus K plus ATPase, which is a protein which is also called as proton pump. Okay, now coming to the goals of anti-ulcer therapy. What are the goals of anti-ulcer therapy? Anti-ulcer therapy means first one is relief from the pain. The next one is promotion of ulcer healing. The next one is prevention of further complications and prevention of relapse. These are the goals in the treatment of ulcer. Now, coming to the drugs, we have a group of drugs. That is, first group is neutralization of gastric acids, which is seen with the antacids. And antacids, we have two type of antacids aware. That is systemic antacid and non-systemic antacids. The next group is the drugs that causes reduction of gastric acid secretion. The next one is which will protect the ulcers. We call it as ulcer protective agents. The fourth group of drugs are anti-pylori agent. As I said earlier, H. pylori, Helicobacter pylori, is the gram-negative microorganism which causes ulcers. So, if the cause of ulcer is Helicobacter pylori, then we have to add antibiotics to suppress the growth or to kill the Helicobacter pylori. So, Helicobacter pylori. So, the fourth approach for the treatment of peptic ulcer is anti-H. pylori agents. Now, first one, antacids. These are the substances which will neutralize the gastric acids. Simple chemical reaction will happen between acid and antacids, whereby it will neutralize the gastric acid. And antacids are classified into two types. One is systemic antacid. The next group is non-systemic antacid. Systemic antacid, the compound is sodium bicarbonate, which is given mainly by parenteral route of drug administration. Apart from neutralizing the gastric acid, it also neutralizes or it causes systemic, or it increases the pH in systemic, and it is helpful in excretion of acidic drug poisoning or overdosage. The next one is non-systemic antacids. These substances include aluminum hydroxide, aluminum phosphate, magnesium trisilicate, megalrate, magnesium oxide, magnesium hydroxide, and calcium carbonate. These substances, these non-systemic antacids, will only neutralize the gastric acid. Okay, these substances will not show any action on the, apart from GIT, does not show any action. I mean, it does not neutralize the acids. Now, antacids, coming to chemistry, these are the weak bases. As these are the weak bases, it will react with the acid and it will neutralize the gastric acid. Okay, it will react with the gastric hydrochloric acid to form salt and water. Next one is this antacids will promote mucosal defensive mechanism through stimulation of mucosal prostaglandin production. Apart from neutralizing the gastric acid, what antacids will do is, it's a small minor action. What it do is, it will stimulate the mucosal prostaglandin production. Now, what are the adverse reactions? The adverse reactions that are seen with the antacids are aluminum containing antacid causes constipation, intestinal infection, anorexia, weakness, tremors, and bone death. These are the adverse reactions that were reported with the aluminum containing, whereas magnesium containing antacids, adverse effects that are seen are severe diarrhea, dehydration, hypermagnesemia, which may cause uh, nausea, vomiting, hypotension, and decreased respiration. Okay, now to counteract the severe diarrhea with the magnesium, to counteract the constipation which is in aluminium, to counteract these adverse effects, what can be done is aluminum preparation can be combined with the magnesium to control the constipation of aluminum and diarrhea of magnesium. Next, calcium containing antacids. There will be rebound hyperacidity will be seen with the all the antacid, especially with the calcium containing antacid. And this calcium containing antacid causes metabolic alkalosis. That is, it also has got systemic action, and it also causes hypercalcemia, vomiting, confusion, headache, renal calculi, and neurologic impairment. These are the adverse effects which are seen with the calcium containing antacids. The next one is systemic antacid, that is sodium bicarbonate, which causes systemic alkalosis. That means it will increases the pH in, apart from GIT, it also shows also increases the pH in other systems. Okay, and this substance also has got, as I said earlier, all the antacids has got rebound hypersecretion will be seen. Rebound hyperacidity will be seen with the almost all the antacids. No, contraindications, precautions, and interactions. Conditions where we cannot go for antacids, and the conditions include during lactation, the antacid should not be given. Why? If it is given, it causes severe abdominal pain. Okay, and cause for the severe abdominal pain is not known. Okay, and sodium bicarbonate containing antacids are contraindicated in cardiovascular problems such as hypertension, cognitive congestive heart failure, and sodium restricted. What is going to happen if sodium containing antacids are given? The sodium levels in the body will increase. So as it is not required in hypertension, congestive heart failure, and sodium restricted diet, it will increase the sodium levels. That's why sodium containing antacids are contraindicated in these conditions. Next one. Calcium containing antacids are contraindicated in renal calculi and hypercalcemia. Already the patient has got problem with hypercalcemia and renal calculi. In this condition, if we give calcium containing antacids, again it will worsen the condition. Thereby, calcium containing antacids are contraindicated in these conditions. The next one is aluminum containing antacids are used cautiously in patients with gastric outlet obstruction. Why? Because aluminum main adverse effect is constipation. So it will worsen the condition. That's why it is contraindicated. Next one, magnesium and aluminum containing antacids are cautiously given in patients with decreased kidney function. These antacids will interfere with the other drug actions. How it interfere means by three ways it will interfere with the other drug actions. First one is by increasing the gastric pH. Now we have certain group of drugs which will be absorbed at acidic pH. Now when antacids are given, what it will do? It will increase the pH. Whenever pH is increased, then the absorption of weakly acidic drugs will be decreased. And the drugs like digoxin, phenytoin, chlorpromazine, and isoniazid absorption will be decreased. Okay, first type of drug interaction. The next one is absorbing or binding drugs. Now, these antacids will react with the other drugs and thereby decreases the absorption of those drugs. And for example, tetracycline. When tetracyclines are given along with the antacids. Antacids will react with the tetracycline, especially calcium containing antacids will react with the tetracycline and inhibits the absorption of tetracycline, and the effect of tetracycline will be decreased. Next one is affecting the rate of drug elimination. Now, these drugs, by increasing the urinary pH, what these drugs do means these antacids will increase the or causes alkalosis in urine. If alkalosis is there, acidic drugs will be converted into ionized substances, and ionized substances are easily excreted. Okay, thereby the drug elimination will be increased. And which drugs will be eliminated more? Especially acidic drugs like salicylates, quinidine, and amphetamine will be increased. Sorry, salicylate excretion will be increased, whereas quinidine and amphetamine, which are the basic drugs, these drugs in basic medium, they will not get ionized. They will be present in unionized form. And unionized form cannot cross the biological barrier and it will not be excreted. So the duration of action of quinidine and amphetamine or simply basic drugs will be increased with the antacid, and acidic drugs will be decreased with antacid. So these are the three drug-drug interactions which are seen with the antacids. The following drugs have decreased pharmacological effect when administered with the antacids, that is corticosteroids, digoxin, chlorpromazine, oral iron products, isoniazid, phenothiazines, ranitidine, phenytoin, valproic acid, and tetracycline. How? Because of the three drug-drug interactions which we have seen in the previous slide. Okay, because of these three drug-drug interactions, the effect of these drugs will be decreased. Now, next group of drugs are the drugs that causes a reduction of gastric acid secretion. First one is proton pump inhibitor. These drugs will target the H plus K plus ATPase or proton pump and inhibit the proton pump. And next is H2 blockers. The drugs are cimetidine, ranitidine, famotidine, roxetidine, and fluoxetidine. The next one is prostaglandin analogs. The drugs include misoprostol and enprostol. The next one is anticholinergics like piperazine and pyrazine and tilenzepine are used. First one, H2 blockers. Now, this one we have seen in the previous slide how the acid will be, how the H plus ions are secreted to the lumen of stomach. Now, H2 blockers, what they will do? They will inhibit the binding of histamine to the H2 receptor, thereby inhibit the activation of adenyl cyclase. If adenyl cyclase is not activated, then cyclic AMP will not be produced. If cyclic AMP is not produced, then there is no activation of protein kinase. If there is no activation of protein kinase, then there is no activation of proton pump is same. This is how the H2 receptor antagonist will inhibit the acid secretion from the parietal cells. Now, coming to the pharmacokinetic properties of H2 blockers or H2 antagonists, first pass metabolism is seen with the H2 antagonist, and absorption is enhanced by food and decreased by antacids. Next one is this drug undergo renal elimination, and dose reduction is required in cases of renal failure patients. Adverse effects and interactions: it causes diarrhea, constipation, headache, confusion, and drowsiness. And these drugs are given by intravenous infusion, should be given slowly. And these drugs has got anti-androgenic and inhibit the estradiol degradation, and thereby it causes galactorrhea in females and gynecomastia in males, thereby it causes impotence. And apart from this, it also inhibits the enzyme CYP450, and the substances which will get metabolized by the CYP450 will be stopped. Okay, thereby the blood alcohol concentration will be increased. When the patient has taken H2 antagonist and this enzyme will be inhibited, that is CYP450 enzyme will be inhibited, thereby blood alcohol concentration will be increased. And nowadays, the H2 antagonists are not used therapeutically much. And the doses and uses are cimetidine, famotidine, and roxetidine. Ranitidine is not used because it has got some substances which are carcinogenic. Okay, so in most of the countries, ranitidine is blocked, banned. Uses: these are used in peptic ulcers, gastroesophageal reflux diseases, stress ulcers, and prophylaxis of aspiration pneumonia. Again, next is proton pump inhibitor. Now, what these drugs do is these drugs will inhibit the proton pump. That is, final step of H plus secretion is by proton pump. So these proton pump inhibitors will directly inhibit the proton pump and inhibits the production of HCl. These are the prodrugs. Prodrugs means these are the inactive drugs when taken orally in the blood or at the site of action. This drug will be converted into active. Inactive drug converted into active drug. The body is called as, that group of drugs are called as prodrugs. Prodrug that require acidic environment for activation. Okay, here in the acid medium or in the stomach, what this proton pump inhibitors will do is will be converted into active substance. And once it is activated, it will diffuse into the parietal cells and accumulates in acid secreting caniculi and gets activated there. Now, sulfonamide will bind covalently with the H plus K plus ATPase and irreversibly inhibit the proton pump. What you have to remember here is the proton pump inhibitors will bind to the sulfonamide group or sulfonamide structure present in the caniculi of secretory cells of parietal cells and thereby inhibits the H plus K plus ATPase or simply proton pumps. Acid secretion resumes only after new proteins are synthesized. That is, new H plus K plus ATPase is synthesized, then only acid secretion will occur. Coming to the pharmacokinetics, these drugs are given as enteric coated granules, in capsules as enteric coated capsules. And this drugs has to be taken before meals, that is 30 minutes before meals. The plasma half-life of the drug is 30 minutes to 2 hours. And these are the hit and run drugs given once then. And these drugs are metabolized by the CYP enzymes, and the maximal acid inhibition requires several instances. And dose reduction is required in hepatic failure patients. Coming to the individual drugs, omeprazole 20 mg per day to given, rabeprazole 20 mg per day, lansoprazole 30 mg per day, and pantoprazole 40 mg per day. And these drugs are given once daily before 30 minutes before meals. And even intravenous preparations are also available, especially pantoprazole intravenous preparation is available. Mostly nowadays proton pump inhibitors are used. Coming to the adverse effects and interactions, these are well tolerated. Gastrointestinal disturbances were observed and hypergastrinemia may occur, and these drugs will interact with warfarin, diazepam, phenytoin, cyclosporine, and inhibits their elimination. And these drugs will increase the clearance of theophylline and chemotherapy. And H2 blockers should not be co-administered. Why? Because what these H2 blockers will do, will inhibit the enzyme CYP450, and proton pump inhibitors will get metabolized by CYP450 enzyme. That's why H2 blockers and proton pump inhibitors should not be given together. Coming to the uses, These drugs are used in peptic ulcers, that is by drug-induced peptic ulcer or because of stress-induced ulcer. Apart from that, it is also used in gastroesophageal reflex diseases and Ellison syndrome, where there is an hyperacid secretion to be seen, and in H. pylori receptor. These are the indications where proton pump inhibitors are used. Next one, anticholinergics, that is especially pyrazine and telenzipine. Apart from these two, propanthyline and oxyphenonium are also used, and these drugs are used very less nowadays. And what they will do is they will block the M1 receptor, and these drugs also inhibit the histamine. The side effects seen with the anticholinergics are dry mouth and blurred vision will be seen. The next one is prostaglandin analogs. The drugs include misoprostol and prostil and erioprostil. These drugs will go and bind to the PGE2 receptor, which is present on the parietal cells, and inhibit the adenyl cyclase enzyme, thereby inhibit the conversion of ATP to cyclic AMP. And apart from this action, it also stimulate the mucus and bicarbonate secretion. It also enhances the mucosal gland. These are the three actions of prostaglandin analogs. And other actions include stimulation of intestinal electrolyte and fluid secretion, intestinal motility, and uterine formation. Next one, misoprostol, which is a PGE1 analog, stimulate the mucus and bicarbonate secretion, it binds to the EP3 prostanoid receptor, and decreases the acid secretion. And the adverse effect is it causes diarrhea, abdominal cramp, and abortion. Why this misoprostol causes abortion? Because we have prostaglandin receptors on the uterus. Now, when this misoprostol is taken by a pregnant woman, this misoprostol will go and bind to the prostaglandin receptors on the uterus and thereby causes contraction of the uterus. That's why abortion will happen if misoprostol is taken by the pregnant woman. Next one, this drug is approved for the NSAIDs induced ulcers, and it is given in the dosage of 200 micrograms. Clinical uses, patient who are on long-term therapy of NSAIDs, misoprostol is combined with the NSAIDs. An adverse effect and drug interaction, it causes diarrhea, cramping, and abdominal pain. Stimulate the uterine contraction, that way abortion may happen, and not used during pregnancy or in women in pregnancy. Next one, mucosal protective drugs. The mucosal protective drugs are sucralfate, colloidal bismuth subcitrate, ranitidine bismuth subcitrate. These are the mucosal protective drugs. Now, how these agents will protect the ulcers means they will coat the ulcers and abortions. They will form a protective layer, thereby prevent the exposure of HCl and pepsin to the ulcers or to the site of ulcer. And the next one, it also stimulates the prostaglandin, mucus, and bicarbonate secretion. These are combined with the antimicrobial agents in the treatment of H. pylori, anti-H. pylori receptor. First one, sucralfate. This sucralfate in acidic pH, what is going to happen is it will polymerize, and this polymerize is a sticky gel and it will adhere to the ulcer base and it will cover the ulcer. It will precipitate the surface protein and act as a physical barrier. It will prevent the exposure of HCl and pepsin to the ulcers. And the sucralfate is given in the dosage of 1 gram QID 1 hour before meals. Constipation is the most common side effect seen with the sucralfate. Next one, sucralfate interferes with the absorption of tetracycline, fluoroquinolone, and phenytoin gas. 2 hour interval should be required. If the two drugs has been given, then the duration between first drug and the second drug should be at least 2 hours. And antacid should not be co-administered. Why? What is going to happen if antacids are co-administered with sucralfate? Antacids will increase the pH. And what is required for sucralfate? Sucralfate require acidic medium. In acidic medium only, the sucralfate will get polymerized. So, antacid should not be co-administered with the sucralfate. And topical formulations are also available for burns, bed sores, and diabetic or radiation ulcers. Next one is colloidal bismuth compound. These also coats the ulcer and stimulate the mucus and bicarbonate secretion. This colloidal bismuth compound has got minor antimicrobial activity against the H. pylori. An adverse effect is it causes blackening of stool and tongue will be seen. And this drug is not used for a long period because of bismuth toxicity. Adverse effect causes blackening of stool. Liquid formation may cause harmless darkening of the tongue. And these drugs should be avoided in a renal failure or renal insufficiency. And last is H. pylori, anti-H. pylori regimen, where the antibiotics are added in the treatment of ulcers to eradicate the H. pylori. Now, the triple therapy regimen for 14 days is omeprazole and lansoprazole, which are the proton pump inhibitors, which are given at the dosage of 20 or 30 mg BID respectively, and clarithromycin, which is an antibiotic to eradicate the H. pylori, will be given at the dosage of 500 mg BID, and amoxicillin or metronidazole, which is again the next antibiotics, two antibiotics with one proton pump inhibitor. And amoxicillin and metronidazole is given at the dosage of 1 gram or 500 mg BID respectively. Now, quadruple therapy, where 4 drugs are given for 14 days. Of these 4 drugs, 2 are antibiotics, one is proton pump inhibitor, and another is bismuth substance. Okay, omeprazole, lansoprazole, same dosage. Bismuth subsalicylate, which will be given at the dosage of 525 mg QID before meals. And next one is metronidazole and tetracycline, which are given at the dosage of 250 mg and 500 mg QID. Okay, so these are the drugs used in the treatment of